Hi everyone, thank you so much for joining us today and welcome to this month's Lunch and Learn research seminar on supporting children living with fetal alcohol spectrum disorders and their carers. I'm Jessica Stewart, Executive Director of Family and Community Services, Insights, Analysis and Research, also known as FACSIAR in the New South Wales Department of Communities and Justice. And before we begin, I would like to acknowledge that wherever we are joining today's webinar from across New South Wales, we are all living and working on Aboriginal land that was never ceded. I'd like to acknowledge the Bidjigal and Gadigal people who are the owners and First Nations people of the area where I have the privilege of joining you today. And I'd like to pay my respects to all the First Nations elders past and present and extend that respect to our Aboriginal colleagues joining us today. I'd also like to warmly welcome all of you, our webinar participants. This month we've had over 1,900 people register, which is our largest number to date, and it really shows the interest and importance of this topic, not only to frontline staff and practice specialists, but staff from other government departments and across the sector. So in today's FACSIAR webinar, we will be hearing from Professor Elizabeth Elliott from the University of Sydney and the Children's Hospital at Westmead, who will present information on fetal alcohol spectrum disorders, including its prevalence and how and when it presents. Following this, we'll have a presentation from Emily Stocker, a clinical psychologist from the Department of Communities and Justice, who will present case studies and discuss lessons for casework practice. We will close off with Rose Casolis from the interagency team at DCJ, who will talk about what can be done to encourage positive outcomes for children in care with FASD, including meeting their health needs through the out-of-home care health pathway program. So after the presentations, I'll lead a Q&A session with the panel. Please put any questions or comments you have for our speakers in the chat during the presentations, and I'll come to these at the end. Please bear in mind questions relating to specific cases cannot be answered in this session, and there will be links in the webinar page with resources for frontline workers to access tools and support for specific cases. I also just wanted to let everybody know that this session is recorded and will be posted to our FACSIAR webpage. Anyone who's registered for the webinar will receive the link to the recording within the next week. So at this time, I would like to introduce our wonderful presenters for this afternoon. Professor Elizabeth Elliott, AM, is a distinguished professor in paediatrics at the University of Sydney, a consultant paediatrician at the Sydney Children's Hospital Network at Westmead, and an NHMRC Leadership Fellow. Elizabeth is head of the New South Wales Service for Assessment and Management of Fetal Alcohol Spectrum Disorders and co-director of the Centre for Care and Intervention for Children Affected by Drugs and Alcohol, or CICADA. Welcome, Elizabeth. Emily Stocker lives, works and plays on beautiful Anawan country in the northern tablelands of New South Wales. She has been working as a clinical psychologist with DCJ in Armidale for the past 8 years. Emily is passionate about the work she does and brings her lived experience of caring for a wonderful young person with an acquired brain injury to this conversation today. Welcome, Emily. And we have Rose Casolis. Rose is the Program Officer and coordinates the Out-of-Home Care Health Pathway program within the Interagency Child and Family team in DCJ. Rose has a strong passion for working in child protection. Rose is a social worker and has experience working within DCJ in child protection and out-of-home care and clinical experience in violence, abuse and neglect services at the Sydney Children's Hospital and the Out-of-Home Care Health Pathway program in South Eastern Sydney Local Health District and Sydney Local Health District. So thank you very much for joining us today, Rose. So thank you all. This is a wonderful webinar that we have ahead of us, and please go ahead, Professor Elliott. You may need to unmute your microphone. Thank you.
Thanks very much for the introduction. I'm pleased to be able to talk to you today about a topic which is very challenging. First of all, you might ask, is alcohol use in pregnancy still a problem? Why does it matter? Well, we know that women are still drinking alcohol in pregnancy. They tell us that they drink before they realise they're pregnant, and most of them will stop once they realise that they are pregnant, but may have drunk a significant amount before that. We know that alcohol crosses the placenta, that it's neurotoxic, toxic to the brain and the nervous system, and it's teratogenic, that is, it can disrupt the development of organs and cause birth defects. It may also have what we call epigenetic effects, switching genes on and off that will confer risk for adverse health outcomes later in life. But the risk to the individual is unpredictable because everyone has different genetics for metabolizing alcohol, different weights, different body compositions, different liver function. And hence the advice is if you're trying to get pregnant or when you're pregnant, you should avoid alcohol. We know in Australia that binge drinking is common in teens and young women, that unplanned pregnancy rates are high, and that any child exposed to prenatal alcohol may be at risk of harm, including of fetal alcohol spectrum disorder. So what is fetal alcohol spectrum disorder? Well, it's a potentially preventable but difficult to prevent permanent disability, which we know is caused by prenatal alcohol exposure. It's characterised by severe neurodevelopmental impairment across several different functions. And the presence of birth defects and abnormal facial features depends on when the exposure occurs. So they will only occur if there's exposure in the first trimester, the first 12 weeks of pregnancy, when these organs are forming. We know that often these children have many coexisting diagnoses. They might come to us with diagnoses of autism or conduct disorder or ADHD. And we also know that this exposure can have lifelong consequences. This is an acquired brain injury. And my final point really here is that you will all see patients with fetal alcohol spectrum disorder. Even if they may not have a diagnosis, you will see parents of children that you come into your care who have this disorder. So it's very important not to be able to diagnose it, but to recognise its characteristics. So what is the prevalence of fetal alcohol spectrum disorder? Well, globally, perhaps 1 in 100 of the general population, but this is very variable depending on how frequently alcohol is used in pregnancy. So it might be as high as 11 per 100 in South Africa. We know that it's the commonest cause of birth defects and intellectual disability internationally. And as I said, it's potentially preventable. In Australia, we don't really have good estimates in the general population. We estimate between about 3.6% of the general population, but we know that there are certain high-risk groups. And these are groups of children that you will see in your services who have a much higher prevalence. So we know, for example, in some remote Aboriginal communities where there's been decades of high alcohol use, such as the work we did in Fitzroy Valley in Western Australia, 1 in 5 primary school-aged children had this diagnosis. And from work that Carol Bauer's done in juvenile justice, 36% or 1 in 3 children have a diagnosis of fetal alcohol spectrum disorder. Now, most of these children, this diagnosis was not recognised before they ended up in juvenile detention. Many of them had never had an assessment, so no one was aware of their capacity or their limitations. So briefly, how do we diagnose this disorder? Well, we want confirmed prenatal alcohol exposure, and that's where you can really help us if you can get that history from the obstetric records, the child protection records, the medical records of the child. We look for neurodevelopmental impairment, as I said, across at least 3 domains, and we look for these physical features knowing that they may or may not be present. We're also very careful to exclude other contributors to neurodevelopmental impairment. This includes a wide range of genetic disorders. It includes things like iron deficiency and lead poisoning. It includes severe early life trauma, brain injuries from other causes, such as meningitis or physical injury. So when we do our assessment, we use a multidisciplinary approach. We have a team with paediatricians and a whole range of allied health professionals and psychologists and social workers. and we assess these domains of function. So, for example, speech and language, motor skills, academic achievement, IQ, and we want to see severe impairment in at least 3 of these domains to fulfil criteria for this diagnosis. As I said, we do look for these characteristic features, which occur in about 1 in 5 of children that we see. So the narrow eye opening or the narrow palpable fissure, because alcohol determines the development of the midline facial features. This flat philtrum, or the area between the bottom of the nose and the lip, flat indistinct philtrum with the absence of those grooves, and the thin upper lip. And you can see in a Caucasian child and an Afro-Caribbean child in these panels that ranks 4 and 5 are considered to be abnormal. And if you've got all 3 of these features, then it's a very suggestive that alcohol exposure has occurred in the pregnancy. But I just want to reflect that the effects of alcohol are different in different settings. So every child is different. We know that the effects of alcohol exposure in pregnancy depend on the dose, the timing, the frequency, and the presence of other drugs. So increasingly, we're seeing that children who are exposed to more than one substance in addition to alcohol will have some worse neurodevelopmental outcomes. Of course, pregnancy complications, fetal and maternal genetics can all influence the development of a child. The fetus maybe will also have its own susceptibility, and then postnatally, and again, this relates to many of the children that you will see. Children might be subject to early life trauma such as neglect and abuse, overcrowding, domestic violence, alcohol and drug use in the home, and all of those things can significantly impact neurodevelopment. And I've mentioned some of these other things, head injury and CNS infection. Multiple placements is also disruptive to children, as we know, and they may have other diagnoses in addition to fetal alcohol spectrum disorder. Now, this slide's just to remind you that the effects of this brain injury are lifelong. So we know that as these children go into adolescence and adults, they continue to have challenges. They have higher rates, for example, of mental illness and drug and alcohol use, higher rates of contact with the justice system and failure of dropping out of education. The median age of death in adults is about 34, which seems extremely low, often due to drug and alcohol problems and sometimes to self-harm. But regardless, this has a huge personal, economic and social burden, and really we need to be working towards prevention. Increasingly, we're recognising that people exposed to alcohol and other drugs in utero have a risk of significant adverse outcomes in later life, and that might include things like abnormal cardiac function, hypertension, metabolic disease such as diabetes, and a whole range of renal, immunological and respiratory disorders. So why should we diagnose this? There's been a lot of dispute. Should we be calling this fetal alcohol spectrum disorder? Is it stigmatising? Well, we know the earlier we can make the diagnosis, the earlier we can provide treatment and the better the outcomes will be. We know that the diagnosis, certainly in Australia, allows access to government funding, NDIS, and certain MBS item numbers. We know that it helps families and teachers and justice professionals, health professionals, understand a child and an adult better and adjust their expectations. It allows us to provide educational support and also, importantly, in your case, to support foster and adoptive families to deal with this problem. It also, because I've mentioned the health outcomes that might occur later in life, allows us to monitor health across the lifespan. It also is useful for prevention. If we see a woman with a young baby who's been affected by alcohol, it gives us the opportunity to offer her the supports to help her prevent drinking during the next pregnancy. Now, one young adult friend of mine who's living with fetal alcohol spectrum disorder said a diagnosis is the key that unlocks understanding, the gateway to support, and the first step towards healing and hope. That recognition can be transformative for individuals living with FASD and the families who stand by them. Now, we have a method of looking at the national data on fetal alcohol spectrum disorder, and I'm just going to take you through that briefly. We receive reports every month from paediatricians all over the country who've newly diagnosed cases of fetal alcohol spectrum disorder. And you can see from this map here that the bulk of those come from the East Coast, including New South Wales. And on the picture on the right, you can see the Australian government-funded clinics represented by those stars. So what is the typical child we're seeing? Well, this is data from over 1,300 children reported through the Australian Paediatric Surveillance Unit. And what we see is children present to us at about 8 years of age, early primary school. The majority of them have been exposed to high levels of alcohol, but many to other drugs. Many of them, nearly 80%, have been in out-of-home care. 75% have had contact with child protection, and only 22% of them are living with their biological family. Boys and Aboriginal children are overrepresented, and many of these children have encountered early life trauma. Now, if you look at the New South Wales data, about 23% of all the cases come from New South Wales, which is pretty equivalent to the population of about 32% of children under the age of 15. About half of these kids have significant birth defects. 1 in 5 have microcephaly. That is a brain that's significantly damaged and smaller than expected for age and gender. And importantly, 1 in 5 have an affected sibling. So we've missed opportunities to prevent this in multiple siblings. And we often see families of kids of 5 or 6 who are all in different foster homes who all have this diagnosis of fetal alcohol spectrum disorder. And children living in remote settings are also overrepresented. I put this slide up just to remind us that there is often a pathway from this diagnosis into out-of-home care, into contact with juvenile justice. And this has been recognised in several national inquiries. So just briefly, where can you refer patients in New South Wales? Well, we run the Fetal Alcohol Spectrum Disorder New South Wales Assessment Clinic for fast, accessible screening and diagnosis. We'd like it to be faster if we had more funding. We receive a small amount of funding from the New South Wales Ministry of Health, and currently we have a 4-year grant from the Australian Department of Health and Aged Care. Now, we are part of the CICADA service, so that consists of the Fetal Alcohol Spectrum Assessment Service, the Family Service for kids living in families with drug and alcohol use, and the Adolescent Service for adolescents who themselves are using drugs and alcohol. As I said, we're funded by the Department of Health, New South Wales and federal. And we have strong links with other groups such as the Department of Community and Justice through the ELVA program, the New South Wales Children's Court, including the Koori Court, the Healthy Communities Foundation, which serves kids in remote New South Wales, and the parent body, the National Organisation for Fetal Alcohol Spectrum Disorder. So we provide a trauma and FASD-informed multidisciplinary diagnostic service, and we have a multidisciplinary team, as I've mentioned. And importantly, because of the overrepresentation of Aboriginal children in our service, we employ 2 Aboriginal care navigators, a male and a female, who make contact with all the families that identify as Aboriginal. We have our standard clinic service, and we also offer a fast track service. So if you've got a patient who seems to have had a lot of assessments by allied health professionals, we will do a consultation with the doctor rather than seeing that child from scratch, and often with them help them establish through case conferencing a diagnosis and a management plan. We have a baby clinic for children up to the age of 4, and we get a lot of referrals from neonatal units and from the Substance Use in Pregnancy program. I've mentioned our other external partners, including ELVA, our outreach service, and the No FASD. Now, just last week we were up in Warren providing a service to 6 children who it would have been very difficult to bring them and their families down to Sydney. We've also done a similar thing in Broken Hill and Collarenebri, and later this year we'll be going to Orange. So we get a lot of referrals. We've had well over 800 referrals in the last 10 years, and we've diagnosed 311 children with fetal alcohol spectrum disorder. But those other children have benefited from the assessments, because even if they haven't had a diagnosis, we've been able to address their challenges. We do have a long wait list, and that's why we've developed the baby clinic and the fast track service to try and sort of speed things up. The referrals we're seeing in the New South Wales clinic are very similar to the characteristics of the children that I showed you in the national data set. Early primary year, males overrepresented, Aboriginal and Torres Strait Islander kids overrepresented, and usually the period from referral to diagnosis is about 2 years. The majority of kids come from major cities, but regional and remote areas are overrepresented, as are children in out-of-home care and children living not living with their biological parents. And 1 in 10 of the children in our setting, as opposed to 1 in 5 in the national data, have these 3 characteristic facial features. Now, what sort of problems do these children present with? Well, I mentioned that we need to see impairment in at least 3 areas to make the diagnosis, but some of these children have impairment in up to 7 domains of function. Most commonly, things like attention, adaptive behaviour, IQ or cognitive problems, language, and executive function. And if we look at the children who have a DSM diagnosis, you can see that we have many children with pre-existing diagnoses or diagnoses we make. For example, ADHD, communication disorder, motor disorders. So there's really a huge complexity to the clinical presentation of these children. Now, our families often wait many years for a diagnosis, have seen many different health practitioners, and this has a significant impact on the families. So when we look at the psychological function of families, we find that the more severe the problems the child has and the longer the period till diagnosis, then the more adverse the outcomes for the families. So if you want to refer a patient, this is the email address, scHN-FASD@health.newsouthwales.government.au. And the key thing that we require for referral is confirmation of prenatal alcohol exposure. And it's important when we're getting that sort of information that we address this issue of stigma. Women tell us they want to be asked about alcohol, they want to be advised. And we do need to realise that women aren't drinking to harm their babies. Many drink before they realise they're pregnant, they're not aware of the risks, they've had conflicting information, or they just can't stop drinking, they've got an alcohol dependency. So we also hold education workshops, and there are 2 coming up, one in Sydney on the 4th of August and one in Orange on the 1st of September, which is open to a whole range of professionals, including health professionals and educators. I'm just briefly going to run through some of the resources which will be provided in your pack. We have a government-funded FASD Hub Australia with information particularly relevant to health professionals, policymakers and researchers. We have a Learning with FASD website of particular relevance to educators, and we have just expanded the information available on that from information specifically for primary workers to secondary teachers. We have resources for early childhood educators. We have the No FASD website, which provides information for parents and families and advocates for them. And there are a lot of prevention resources available, including our national guidelines and resources from the Every Moment Matters campaign developed by the Foundation for Alcohol Education Research. NACCHO, as part of that campaign, has developed special resources for health professionals working with Aboriginal families, and New South Wales Health also has the alcohol and pregnancy resources, which are very nice little short videos which are very helpful for educating health professionals. So really, in summary, really the role of DCJ caseworkers is to understand substance use behaviours in the mothers and fathers of the children that you see, and to at any possible opportunity to document prenatal alcohol exposure, whether by direct report, witness report, or from official records. It's really important that you advocate for assessment of a child with prenatal alcohol exposure at the earliest possible occasion, that you attend case conferences and feedback with families. You enable families who have a diagnosis to connect with NDIS and with providers, and that they get appropriate local follow-up. Be proactive. Acknowledge that many families are overwhelmed, financially stressed, and lack practical assistance such as transport. Now, we very recently had a case where a DCJ worker really was very proactive in helping a 17-year-old boy who presented to us from juvenile justice. He had a child, he had his own problems with substance use, and the caseworker was really helpful in joining the case conference, linking this young boy with Aboriginal residential rehab after custody, and linking him with a support program for fathers who came out of justice care. So in summary, this is an increasingly recognised chronic and complex problem. You will see it in your service. We have a diagnostic approach, a guide to promote a systematic approach to diagnosis, but we need early diagnosis, and you can help by identifying children at risk, by identifying those who've been exposed prenatally to alcohol. Thank you, and I'd like to hand over to Emily.
Thanks so much, Elizabeth, and thank you for the opportunity to talk to you today. So I'm Emily. I'm a clinical psychologist with DCJ in Armidale in the beautiful Anaiwan country in the northern tablelands of New South Wales, Big Sky country. So I want to talk to you a little bit about the work that I encounter and give you a bit of a case study example to give you a sense of what it's like or what I've encountered working in this domain. What I've noticed, I'll typically start with a referral from a caseworker for assessment. I find that the young person, go back there. Yep, not going back. Let's try this again. Okay, so a referral from a caseworker, typically for assessment. The child is often navigating difficulties with regulation. They're often disconnected from family, had many disrupted relationships, and they're often coming with a litany of diagnoses. They're overwhelmed. Their care network is overwhelmed. They can be overserviced. Well-intentioned practitioners trying to meet their need, or they could be underserviced and overlooked. There's often this cumulative effect of entrenched negative narratives forming around the young person and a concerning trajectory for that young person. They're misunderstood. So I'm going to tell you a little story about Jack. Here's Jack. He's 9 years old. He likes Roblox. He likes footy and he goes for the Rabbitohs. He loves spag bowl and he hates broccoli. His best mate is Jack, who's a good boy. And he really loves looking after his little sister and helping her make breakfast. Jack's mum and dad were really struggling to navigate their own difficulties when he was little. His environment and the relationships around could be pretty chaotic and unpredictable and sometimes dangerous. Pretty early on, Jack learned that the world could be a dangerous place. He sadly was taken into care when he was 4 years old, and since that time he was subjected to lots of disruptions to really important relationships in his life. And many placement changes, often associated with the difficulties people around him encountered managing the difficulties he was navigating. People were worried about Jack. He was struggling to keep up academically. He struggled with regulation of his emotions and behaviours, and he was often in trouble for not following the rules. He had a lot of relational problems with his peers, sometimes, getting into fights at recess and lunch. On occasion, he was suspended, sorry. In fact, he was first suspended in kindergarten. He had real difficulties paying attention and found it really hard to settle in class and staying still during learning time. He'd come with a few diagnoses that have been given: ADHD, intellectual developmental disability. He was being medicated with Concerta and Catapress. FASD was queried by a previous paediatrician, but I couldn't see any evidence that had been followed up on. He was getting some intervention at some point in time, that it wasn't clear really how much traction that had gotten. He had some work with a behaviour support practitioner, wasn't sure what that actually looked like. He had a behaviour support plan and an individual education plan in place, but he wasn't accessing NDIS. So the referral to me was for assessment of autism spectrum disorder. But I got the sense that we didn't really have a great understanding of what Jack was navigating. So I began with a bit of a deep dive into the records, and I could see that several assessments had been done sort of in isolation in the past, and that there were references to mums struggling to sort of manage her use of alcohol. Throughout the records, there was reference to this. Jack really needed us to get a better understanding of him and what he was navigating. So I was posed with the question, what do I do next? I turned to one of my favourite resources that comes from the wonderful Dr. Vanessa Spiller. It's the ability wheel. You can see here in this wheel that it lists brain domains that are considered in assessment and diagnosis of FASD. Obviously, this was developed before the recent updated FASD assessment guidelines. So it might be slightly different, but what you can see here is the range of brain domains. The different coloured dots tell us a little bit about the level of functioning, with purple being exceptional. Don't know anyone who's operating at that level consistently. Green is around average, and the red dots sort of indicate pretty severe impairment. So if someone functions averagely across all of their domains, their wheel might look something like this, a bit circle-like. And when my wheel looks like this, riding a bike's pretty straightforward. My wheels roll smoothly, doesn't take much of a gentle push to get me rolling and carrying me forward into my day. Steering's pretty direct, and my brakes work pretty effectively. So we arranged a bunch of assessments for Jack. I also, drew upon the assessments that had been done previously, arranged some assessments where there were gaps, and mapping the results onto the ability wheel. This is what Jack's wheel looked like. You're probably going to notice a few things about Jack's wheel. The first is the shape of his circle, which is no longer circle-like. It's easy to imagine how this wheel would roll through life. Many bumps and clunks, getting stuck, veering off in unexpected directions. And the second thing that you might notice is the size of the wheel, which is significantly smaller than the first wheel we looked at. Look, smaller wheels still roll, but it takes a lot more pedaling and effort to travel even just a small distance. The shape of someone's wheel can really make life a lot rougher and more exhausting to ride. And this doesn't take into account the impact of Jack's early adverse experiences. This is just where he's starting every day from. This is where he's starting when he steps out into the world. This is what Jack's navigating, what it might look like for him watching others go by. as he pedals a lot more furiously than others. So once we mapped Jack's unique profile, it was much easier to see the mismatch between where he was at and where the supports and accommodations were required to help him just get along and to thrive. If we look at the green line, that's where the level of ability demanded by the environment is. The blue line shows Jack's abilities, and shading in between those are the areas where supports and accommodations were most needed for Jack. So what we found was when there was a mismatch between his abilities and what was demanded in his environment, when his level of functioning was misjudged, and when reasonable and appropriate accommodations and supports hadn't been accessed, that's exactly where Jack was encountering behaviour that was challenging to others. Now that we had a better understanding of the types of tasks Jack was likely to struggle with, we could begin to tailor therapeutic support in the spaces in between. What did that look like? Well, crucially, we were able to prioritise interventions that Jack needed. Rather than asking Jack to carry the load, we were able to work with those around him in his care network to modify his environment and to modify their expectations. And we did this through education, a neuroaffirming approach, and reshaping the narrative around him. We were able to help fashion a bike that was just right for Jack, a different shaped bike, different kinds of wheels. And look at him go. What a little legend Jack is. Jack needs us to know that he doesn't act the way he does on purpose. It's not his choice, it's just how his brain works. It's not because he won't. Sometimes it's because he can't. Remember, this FASD constitutes a brain injury. The intervention for brain injury is quite different. He doesn't always understand, but he wants to feel connected and fit in just like anyone else. Things might change as he gets older, but he won't grow out of FASD. He needs us to help him succeed by having realistic expectations and providing him the support he needs. Jack's mum wants us to know that she loves Jack very much and she wants the best for him. She's been carrying a deep sense of shame and guilt for a long time. She wants us to know that she thinks Jack's caseworker is a superstar and that she's really grateful to have met her. Jack's caseworker took time to build a dignity-driven, neuroaffirming, culturally responsive relationship with her, such that she could start the process of healing and recovery. And that was important for her, but it was also really important for Jack. Jack might not live with his mum in the future, but he will always have a relationship with his mum. And that's lifelong. So Jack's mum's relationship with Jack also improved and started a healing process. To the practitioners out there, what can we do? Well, get educated. Every day's a school day. Take up opportunities to listen and learn wherever and whenever they present themselves. Thumbs up to you all for being here today, because this is learning right now. Grow your skills to build dignity-driven relationships that are culturally responsive and neuroaffirming. Talk about it. Talk about FASD. Invite conversations. Let's stop it being this diagnosis that's shrouded in mystery, because every interaction is an opportunity for intervention. They're all potentially opportunities to start that healing process. Model the change in attitude. Model the change in attitude that we want to see in our society. Take on a neuroaffirming stance. And be a champion of hope and celebrate difference. These are high stakes in the lives of these children like Jack. And there's a lot of hope to be had when we get this right. I'm just going to leave today with some links to the resources that I've referred to. For those DCJ practitioners out there, collaboration is really vital, and psych services are here to help. You're not expected to do this on your own and know all the things. Reach out to the specialists in your patch. Reach out to psych services, to casework specialists. Reach out to our colleagues in health. Working together as a collaborative group, getting in early and working together as a collaborative group is really much more likely to be able to facilitate those healing and recovery processes and set things up so that kids like Jack can really thrive, not just survive, but thrive. There's a lot of hope. Okay. So I'm going to hand over to the lovely Rose, and all the best for the rest of your day.
Thank you, Emily. So my name's Rose, and I'm the Program Officer within DCJ in the Interagency team. I'm here to talk to you about, I guess, the Health Pathway Program and what's the best way forward, as in how can we navigate such a complex health system and how can we best meet the health needs of children in out-of-home care. So the Out-of-Home Care Health Pathway Program is not an exclusive FASD service. It's thinking about how can I access the Health Pathway Program to help me navigate the health system. So why do we need the out-of-home care health pathway program? Is we know children in out-of-home care, they're known to have complex, unmet and unidentified health needs. We know for children who've been identified, who've been exposed to childhood adversity, may have a difference in their cognitive and social functioning. I invite you to access the Pathways of Care longitudinal study. That does show us that children out of home care are 70% more likely than their peers to be at risk of a delay in their cognitive and social emotional development. They have wonderful resources online. What the POCL study also shows us is that children who access services demonstrated positive physical and developmental gains post-service intervention. We also know that children in out-of-home care continue to face barriers when accessing health services and also achieving a sense of continuity of care. So what do I mean by that? What may that look like? And I guess the things that come to my mind is the availability of services. Can everyone hear me? Yep, okay. So it's looking at the availability of services, and I know that's quite unique to rural areas. If there's a change in their placement, or if a child changes staff who they work with, that's a disruption for that child. That is a risk of information being lost or access to services or kids falling through the gaps. So what is the Health Pathway Program? It was developed in 2010 and it's a joint initiative between DCJ and New South Wales Health to deliver timely and coordinated age-appropriate trauma-informed health assessments, and they also support with service navigation. In New South Wales, the Health Pathway Program is closely aligned and delivered within the National Clinical Framework for Children and Young People in Out-of-Home Care. So you're going to hear me talk about a partnership, and the program is delivered in a partnership model. So it does rely on the close working relationships between health staff, caseworkers, carers, and other health services. To note, in each LHD or local health district, they employ a coordinator, and depending on the district, they may have access to nursing or allied health staff within those teams. Those teams are wonderful. They're a wealth of knowledge. They have knowledge of the services within your district, what's available, and they also have connections to other local health services, such as child and family health nursing, links to Aboriginal controlled health services, youth services, child protection counselling services within the health districts. The overarching aim of the Health Pathway Program is to ensure that children and young people in out-of-home care have their health and developmental needs identified early and responded to as early as possible. So this maps out the key process of the Health Pathway Program. I'm not going to go in detail in the key processes. That is well documented on the New South Wales Health webpage, on the DCJ webpage as well, and within the New South Wales Health webpage, there's a wonderful link to a video on the Health Pathway Program that can be shown to carers and young people. Essentially, though, what happens at the end of the Health Pathway Program, the assessments, is a health management plan is developed, and within that plan, that identifies the health needs of a child and any recommendations to address those health needs. So, in a sense, this document, it gives us some continuity of care. It helps us support children meet their health needs. It's a document that should be and can be used by the team around the child. And when I talk around the team around the child, I talk to the majority of the people that's online here, that being their caseworkers, that being health, that being their GP, that being their carers. It's for us to all work together to meet those children's needs. I guess at a point and a transition point that is at risk, and I do encourage yourself as a caseworker, as a carer, to work with young people to access the Health Pathway Program for a leave and care assessment. What we know is from the age of 15, that is a key transition point. The earlier we can get into plan for their leave and care, the better outcomes for those children. So how does the Health Pathway Program relate to FASD? And I guess everyone online here, we all have a pivotal role in meeting the child's health needs. As I said to you before, the Health Pathway Program is not an exclusive diagnostic service, but I see them as a key partner in helping you navigate the child's health needs and also navigate the health system. What I would like to invite you is to consider a better engagement with the Health Pathway Program. Think about how can I collaborate with them? How can I collaborate with other key stakeholders? How can I use that collaboration to support, trauma-informed and coordinated health assessments being purposeful and targeted? And I think this fits in nicely with both Dr. Elliott's and Emily's presentations to start thinking about that. So when I came to collate this presentation, I thought to myself, what's the foundation of good practice? Is it information gathering? Is it planning? Is it collaboration? And it was hard for me to choose which one to put in first. So I guess the things I want you to think about is that this is not linear. This process is interchangeable, and this process should never stop in your work. So what do I mean by information gathering? It's thinking about when I approach these assessments, be purposeful in your information gathering. Think about what information do I need? Where do I gather that information? Who do I need to gather that information from? Who do I need to talk to gather that information? Is there someone that can help me navigate those questions in terms of who to speak to, where can I get information? Thinking about information when going to these assessments, what information will the health team need? And thinking about collating past information about their past health reviews, any other formalised assessments. Has an assessment been completed in the school? Has it been completed by a private provider? Can I get access to the private provider's records? Keeping in mind that that private provider, their records don't link with public health systems records. It is your role as a caseworker to obtain those records. Obtaining the child's school reports, any type of assessments at school, their birth records, GP records, and past GPs. We know children move around. That's another change in a GP practitioner. So being able to draw all that information together. Having open and respectful conversations with family about their own history. And thinking about their family history. Is there a family history of other diagnoses? How does that relate, and how is the risk factor to the child's history? How can that information be used? Think about how can we include parents in their participation in the health assessment. That might not be them attending the actual appointment, thinking about the amount of adults in that room, but thinking about, can I arrange for them to have a conversation separately with the health team to inform that information? Can they raise their concerns with me so I can pass that on to the health team? So it's thinking outside the box. Having a respectful conversation with the child's mother and their pregnancy journey. And inevitably, that is going to be a difficult conversation no matter what. Think about, was it pregnancy planned? Did they access antenatal care? Discussion drug and alcohol use, including the type, frequency, and when the use occurred. And remembering for that mother that this may carry shame, it may carry guilt, it may carry worry. How will that information be used? Will that be used against me? And, I guess drawing on those respectful working relationships and collaborations with the parent. And if we think about that, it's thinking around what supports can I draw on to help me have that conversation. If I'm working with First Nations families, if I'm working with culturally and linguistically diverse families, are there supports that can help me plan my conversations? And also, I guess, gathering that information from their parents. Ask them on their child's development. Do they have any concerns for them? When did they first walk? When did they talk? All that information is relevant. And a key aspect is a carer and also a teacher. Children spend the majority of time either at school or with the carer. So your knowledge is important. So thinking about their learning, their social skills, their behaviours, their presentations. This information is all important. We underestimate the significance of this information, and I think we think about, oh, it's not really relevant. It's just what they do at school or they're playing on their weekend. This all forms, I guess, part of their picture and the functioning. Sort of what Emily and Elizabeth spoke to us around mapping. And I guess what another key important milestone to think about is planning. What is the best way forward to meet the child's needs? Having a chat to the health pathway program. If there's been a placement breakdown and the child's coming up for an assessment, is now the right time to do that assessment? Think about, when is it the right time? How can I support the child? How can we support a young person to get them to that appointment? Do we need to get them to know the service a bit? Do we need to speak to them about what's the assessment? What's it going to look like? What's they going to expect? If you're a DCJ caseworker, consult with your psychological and specialist services, consult with your other consultants to think about, how do I frame that? What's the language? For NGOs, consulting with those, your other specialist services. And I guess when we look at planning, it's also planning, how can I get the carer to the appointment? How can I support them to attend that appointment? And planning post-assessment, what does it look like? Post-assessment, do we give the diagnosis at the end, or do we give do we structure that, what it means to, what it means on the child, what it means for the carer, what it means for the parents? So it's sort of planning how we deliver the news. And I think also looking at, how do we then support the care environment for that child? How do we optimize that environment? What supports can we put in for the carers? Can we plan parallel assessments? So if a child's on a wait list for a paediatrician, can we organise to have a speech OT assessment, some carer support and therapeutic intervention? And lastly, a key message or a key takeaway from me is collaboration. Please collaborate. Everyone works within their own boundaries, and by collaborating, by bringing everyone together, it's about us being on the same page. It's about us working for a common goal. It's about us being able to provide wraparound support for children and families. And that collaboration is for everyone. So regardless of whether you're a carer, whether you're a parent, a caseworker, a teacher, another health staff member, a clinician, we all need to collaborate. By collaborating, that allows for information sharing to occur at the same time. It allows us to navigate the parallel assessments. It allows us to promote accountability and role clarification. So we all know who's responsible for what, what's next, what's coming up next. It's predictable. It's a joint plan. And I guess collaboration supports targeted service intervention. So intervention is targeted and it's suiting the child's needs. It supports us from reducing duplicate assessments. So for more information, I've included the link to the DCJ webpage, the New South Wales Health webpage, and the PSP e-learning hub. For a caseworker, if you have any questions, please link in with your local health pathways coordinator. I have seen some wonderful things come out of those beautiful working relationships. For a carer, if you've got questions, reach out to your caseworker. There's certainly a lot of support that is there. Jessica, I'll hand over back to you. Thank you.
Thank you so much, and thank you to all of our presenters. That was incredibly important information. And we just have 5 minutes left, so I'm going to quickly tie together the threads in the chat, and thank you to everyone for being so active in the chat. There's a number of comments around how is it best to document prenatal alcohol use to support diagnosis. What's the process if you're unable to access the history in the prenatal period for a young person? And is there guidance in terms of supporting a young person where FASD is suspected, but there's insufficient evidence? I think that's there's a number of comments around that. Perhaps Professor Elliott, if you wanted to just to comment on that one. And then separate but related advice around the National Disability Insurance Scheme and varying experience about whether it is possible to access or not access packages on that. Seems that there's differences in how those assessments are done, whether it is seen as a permanent disability or not. So perhaps if I can turn to you first, Professor Elliott, and then if others wish to comment as well.
Well, firstly, we will use any means of trying to find out confirmed prenatal alcohol exposure. That might be the biological mother, it might be a witness statement from a close relative or someone who lives with the family, or it might be going to the obstetric birth or medical records. If you can't do that, and I think Emily made this point, the assessment process is still very relevant. So from a pragmatic point of view, whether or not you can end up with a diagnosis of fetal alcohol spectrum disorder, you will be able to, in any child, assess their strengths and work on them and assess their challenges and put in place the appropriate therapy.
Thank you. Any other comments from our panel members, Emily or Rose?
I would just reiterate what Professor Elliott just said there, is that even in the absence of evidence of confirmation of prenatal alcohol exposure, this is a real opportunity to lean in and get an understanding of this young person's unique profile. And that often access to the NDIS is really about demonstrating impairment in functioning. And so through this assessment process, with or without confirmation of prenatal alcohol exposure, you should be able to produce a profile that demonstrates their difficulties in functioning, and that should have many flow-on effects for young people, including accessing intervention through things like the NDIS.
Thank you.
Just with regard to NDIS, fetal alcohol spectrum disorder is listed as a permanent disability. It is a permanent disability, even though we hope that we'll be able to improve the capability of children and adults. You know, whether you've or not you've got the diagnosis, you should be able to access NDIS support for these children because of the severity of the impairment across many domains of function.
Thank you. There's also a comment about, is there a link between male use of alcohol during the conception period? Is that something that people need to be aware of?
Look, this is an area of increasing interest for research. I've just come back from a conference in the US and there was a whole plenary on this. Yes, there is increasing evidence that use by the father of alcohol in the couple of months before pregnancy may cause epigenetic changes in the sperm, which may cause problems in the child. Just to be clear, the only way you can get fetal alcohol spectrum disorder is from the alcohol use in pregnancy, because that's a direct effect of the alcohol on the fetus. However, it's possible that paternal alcohol and drug use may also impact the neurodevelopmental outcomes that are seen in children. So it's a complex and emerging area. We'll report back to you at the next webinar.
Thank you. And I wish we had more time. There are so many terrific questions in the chat, but we will endeavour to respond to those after the session. So I'd just like to really thank everyone for joining us today, and just quickly turn to our panel. Each of our speakers, if you had one takeaway message you would like to leave our audience thinking about after this session, and I'll start with you, Elizabeth.
Look, every person with fetal alcohol spectrum disorder is different. They all have strengths and they all have challenges. And the more information you can get, the earlier the better, and get assessments in place, then the better the outcome will be for those people.
Terrific. Thank you. Emily?
Yeah, look, this work has really high stakes in the lives of real people and kids like Jack. So to all the practitioners out there, the relationships you build can be really transformative, particularly when they're dignity-driven, culturally responsive, and neuro-affirming. So don't be afraid to lean into those relationships and ensure as much of a collaborative team around the child in this work.
That's terrific. Thank you. And Rose?
I think collaboration, be the bridge. Everyone needs to be the bridge. Everyone needs to come together, carry the load together.
Thank you so much. Well, thank you to everyone for attending. As usual, you'll receive a link to this webinar within the next week. And we would also like to welcome you to our Lunch and Learn research seminar next month on the 24th of June, which is looking at the New South Wales Drug Court evaluation, positive outcomes for common clients across justice and community services. So we really hope to see you there. Thank you again to our presenters and to all of you for taking the time out of your day to attend. We really appreciate it, and we hope you have a wonderful day. Thank you.